So, she's going to perform an ultrasound of herself. PV bleeding during early pregnancy definitely does merit an ultrasound. We discussed the differentials in the earlier episode, including spontaneous abortion or miscarriage, hydatidiform mole, or ectopic pregnancy.
No, I mean, it's been a while, right?
We are seeing the bladder here, which is full. A full bladder is necessary to observe the uterus which lies behind the bladder. This is the uterus. It's empty with no embryo or fetus and is collapsed. This is the thin endometrial stripe and doesn't lodge fetus or any retained products of conception. Looks like a complete expulsion of fetus, meaning complete abortion.
"16 is open. How come nobody's been..." My bad, it's taken. Sorry.
Mr. Louis was found unresponsive and on the sidewalk next to fine wine and good spirits. Decent vitals, no head trauma.
Didn't we just discharge him a couple hours ago?
Yep, stone cold sober at 7 a.m.
The alcoholic patient from the first episode. Chronic alcoholism will eventually lead to cirrhosis and could very well cause life-threatening hemorrhage. Cirrhosis of liver is a complication of chronic liver disease where the liver tissue gets replaced with fibrosis or scar tissue, the most common cause of this being alcoholism. Over time, due to this scar tissue, blood flow through the liver gets obstructed. This can lead to what's called a portal hypertension. This can then lead to enlarged veins in the esophagus called esophageal varices, which then bleed and cause upper GI bleeding. He also had tremors, which is a common symptom of alcohol withdrawal. This can be accompanied by delirium, where a patient is disoriented and acts confused, also called delirium tremens.
Oh, God, don't light any matches.
Hey, Doc, how you doing?
Not as good as you, Louis.
Hey, you know it, Doctor.
How much did you have to drink, Louis?
Just a couple of shots of vodka.
40% alcohol by volume.
So like a half gallon?
Oh, hell no. Just a quart.
Patients definitely lie when talking about how much they drank. Ideally, you could lie to everybody else but not to your doctor, as we gotta know the units of alcohol consumed, which reflects the actual amount of pure ethanol that's in your body to do damage.
If you over-exaggerate your questions, you usually get a truthful answer. Learn from the best.
This is called anchoring bias, where the first idea presented, which is extreme here, affects the response. Exaggeration sets a high bar that makes lesser truths easier to admit and also help ease tension, making it feel safer to open up and be more honest.
He's got Librium from this morning.
That's what I prescribed him.
Librium, or chlordiazepoxide, is a long-acting benzodiazepine used for alcohol detoxification and to treat alcohol withdrawal symptoms. Important to consider is that the patient ideally has to wait at least 12 hours from the point of taking alcohol before taking this medication. Since this guy is a heavy drinker, it would be advisable to wait even longer. If not, the drug and alcohol both act as CNS depressant and can cause drowsiness and respiratory depression, leading to difficulty in breathing.
All right, Louis, let's scoot it on over. You want to guess the blood alcohol level?
Why would I want to do that?
I don't know, because it's fun.
A heavy drinker like him or a chronic alcoholic would likely be tolerant to alcohol at this point. For tolerant people, they may walk and talk normally at blood alcohol concentration of 0.2 to 0.3%, which would cause stupor in a non-tolerant person. A BAC of more than 0.4 would be potentially fatal.
You prescribed 20 Librium, there's only 10 left.
See you next time.
Shouldn't we be concerned about an overdose?
Oh, no.
That definitely is an overdose, and also immediately took alcohol after. Hence, never discharge a high-risk alcoholic with unsupervised benzodiazepines. If needed, prescribe small quantities with close follow-up or admit for supervised detox. Also, shouldn't we be concerned about respiratory depression here? The patient is intoxicated with both alcohol and benzodiazepines, and the combination would have risk of severe respiratory depression and coma, so he should be monitored for respiratory depression, hypotension, and sedation. Flumazenil is an antidote for benzodiazepine overdose and acts as a competitive GABA A receptor antagonist. However, in chronic alcoholics, it can be used and is contraindicated, as there is risk of CNS hyperexcitability and withdrawal seizures along with life-threatening status epilepticus. But the patient doesn't seem sedated, so is it a case of overdose with intoxication or just intoxication? Even taking one pill and going back to being an alcoholic is risky here.
Vodka is Louis' drug of choice. Quickest way to kill a shake.
Chronic patients often suffer from tremors as a symptom of alcohol withdrawal, and the tremors go away once they start drinking again. I guess this is what Dr. Langdon means here. But that's irrelevant to the question being asked, which is valid. It would be a nightmare if he's overdosed on benzo and is also intoxicated at the same time.
True that.
Where'd the other 10 pills go?
I don't know, maybe lost, stolen, maybe sold him to buy the vodka.
What'd you do with the other pills, Louis?
In my pocket, I didn't need
I guess he didn't take a single pill and is here only with alcohol intoxication.
it. Come on. Give it a rest.
Is everything okay with Carl?
She seems fine to me. Like our patient board.
How's it cracking?
Sleeping like a baby.
The methamphetamine-induced psychosis patient who was injected with haloperidol, which is an antipsychotic, and midazolam, which is a benzodiazepine earlier for sedation and control of the episode of psychosis.
What's the story with beds upstairs?
Ladderfall took the last ICU bed, one telebed's open, no med surge, no peds.
So which one of our 21 boards is going to win the lottery?
CHF.
Chronic problems of almost every hospital are less staffs and less beds. And ER suffers from this the most, by having to keep patients who have already received emergency management and shouldn't still be there.
Exacerbation's been with us for 2 days.
Sounds like a winner.
Cardiac patients have unpredictable disease course that could be fatally interrupted with arrhythmias and hence need CCU monitoring in priority.
The rest will receive our lovely consolation prize packet. Tell them what they want day now. It's another 24 hours of bright lights, screaming trauma patients, hard gurneys, and sleep deprivation, all while you wait for a bed up.
Anyone who has experienced staying overnight in the hospital knows what Dr. Robbie is talking about, so everybody hates hospital stays, except for us as medical staffs, I guess, who are the chronic dwellers of the hospital and have no choice as it's literally our workplace. Everybody else hates our workplace.
Stairs.
Hey, Nandi, the influencer in Central 8, still waiting for psych?
Nope, she's a keeper. Her mercury level's sky high from that face cream.
The heavy metal lab panel has confirmed mercury poisoning, so the psychotic symptoms are likely a result of mercury-induced psychosis. Inorganic mercury was absorbed transdermally in significant amounts while applying the face cream, traveled via blood, crossed the blood-brain barrier, and accumulated in the brain. It disrupted the dopaminergic and serotonergic neurotransmission, causing psychotic symptoms like auditory hallucinations and delusion of persecution, as seen in the patient.
I ordered chelation, TID, 10 per kilo of DMSO.
I guess it's DMSA or dimercaptosuccinic acid, which is a chelating agent used for heavy metal poisoning cases like mercury, lead, or arsenic. The first thing in heavy metal poisoning like this would be to stop the ongoing exposure by removing the dermal contact, if still present, to prevent further absorption of mercury from skin. Then heavy metal chelators like dimercaprol or DMSA could be used. DMSA or succimer binds the metal ions and helps form stable complexes with them, and these are excreted in urine. So they essentially increase the renal excretion of metals and decrease their serum levels, hence acting as an antidote for them. Along with this, hydration with fluids and monitoring of renal function should be done accordingly.
Make sure it comes up from pharmacy. Great pickup.
Hey, you okay?
Excuse me. I'm sorry, Dr. Rabinovich.
Yes, that is me.
Father McGill, here to see John and Lily Bradley.
Ah, yes. Thank you for coming.
No problem.
I will take you to the family room.
Dane, I need some help.
What's up?
Been trying to check the nursing notes on Louis from 7 a.m. this morning.
The notes from the morning rounds, I guess, of the alcoholic patient who was discharged with Librium.
Langdon ordered lorazepam, but I don't think it was given.
Lorazepam is another drug used for alcohol detoxification and to treat alcohol withdrawal symptoms like tremors. It's an intermediate-acting benzodiazepine, unlike the long-acting Librium, and this was likely ordered for inpatient use before discharging on Librium.
Yeah, lorazepam ordered, dispensed, and then returned unused to the PDS per Dr. Langdon as patient's tremor had resolved.
Is that unusual?
No, happens all the time.
You think that could be the vial I couldn't open on our seizure patient?
That's an interesting observation, but why would Dr. Langdon possibly tamper with the vial and return back?
Possibly.
Can we check the other vials in the PDS, make sure they're okay?
Really want to?
I do.
All right, come on.
What are the odds of the vial being used in one patient, being the exact same vial that was returned earlier out of hundreds of similar vials in the pharmacy?
Dysuria, North T's been waiting a long time.
I'll take it. Yep.
Dysuria or burning micturition is usually a sign of urinary tract infection, often accompanied with fever and flank pain.
Oh, Dr. King. Rita,
We were so worried. Oh, I'm so sorry. My phone was on silent. I missed 10 calls from the hospital. Is my mom okay?
Oh, yeah, she's fine.
So the mom wasn't abandoned by the daughter after all. However, she still very much has suffered from caregiver fatigue and must be evaluated and counseled accordingly.
I went to move my car, and it was so peaceful and quiet when I parked in the garage. I dozed off.
I'm just really glad you're back. Oh, your mom is going to be so happy. She's waiting in the hall.
For context here, her mom is a patient of schizophrenia, which is a chronic psychotic disorder, and recently sustained proximal humerus fracture. As the injury would impair the mother's daily activities even more, it was suspected that the daughter abandoned her for fear of more ADLs, essentially adding even more to the daughter's caregiver fatigue.
So if I order lorazepam for Louie, the log shows me we have 5 vials left. Take one out, and now we have 4 left. But if I click that I want to return one unused, you put it back, and the computer count goes back up to 5.
Yeah, same lot numbers, everything looks good.
No way of knowing which vial was returned by Dr. Langdon.
Yeah, so the odds of it being the same vial is pretty low, or you just can't simply figure out. And honestly, in real practical world, it wouldn't be as easy or comfortable to go after a resident like this, suspecting something fishy, even though you might be right. Especially explaining the rationale and reasoning behind looking for this to a nurse, and taking the initiative would be uncomfortable and would rather be deemed as being absurd or even rude, even though you have a valid suspicion.
Yeah, I guess. Thanks.
Yeah.
Old man coming in with a heart rate of 30. Sounds like pacemaker failure.
Bradycardia with a heart rate of 30 beats per minute in an older adult absolutely raises concern for pacemaker failure, especially if the patient has a known pacemaker or there's visible evidence like a chest scar or a pacemaker card. Other causes would include a complete heart block, or could be drug-induced like beta blockers or digoxin, or could be metabolic causes like hyperkalemia or hypothyroidism, or even myocardial infarction, especially inferior wall MI.
Could be a good case.
Putting an amputation in 15.
Amputation is the surgical removal of part or all of a limb or extremity. It is usually indicated in cases of peripheral arterial disease with chronic ischemia, and gangrene, meaning death of limb tissue due to lack of blood supply, trauma like severe crush injuries, infection like necrotizing fasciitis, meaning infection that destroys skin, subcutaneous tissue, and fascia, or osteomyelitis, meaning infection of bone, diabetic foot, or tumors.
Ooh, that one sounds even better.
Rocco DiGiulio, amputation of the 4th fingertip at the base of the nail, bone exposed.
Amputation is usually used as a surgical term, but it can also describe a traumatic event. Surgical amputation is a controlled, planned procedure done in an operating room, while traumatic amputation, like this case, refers to unplanned loss of a limb or digit due to accident or machinery or war injuries.
How'd this happen?
I crushed under air conditioning unit we were installing.
So, this is due to machinery and hence an occupational hazard.
We'll numb up your finger. One shot will help with the pain.
Here, the first steps would be to control bleeding by applying direct pressure, elevating the hand, or using a tourniquet. We gotta stabilize the patient and then proceed to control pain with IV opioids or a digital nerve block. Regarding the amputated part, we have to handle it carefully to preserve tissue for a possible replantation. We gotta gently rinse with normal saline and wrap in moist, sterile gauze. Place in plastic bag, then put that in a container of ice water. Replantation involves microsurgery, which is best for thumb, or if multiple digits were amputated with clean cuts. If not possible, the amputated part is fully detached and the remaining stump should be managed well to restore blood supply and function. Replantation is usually not done if it's a single non-thumb digit in adults. The patient is put on broad-spectrum antibiotics like cefazolin and Metron. Tetanus prophylaxis should also be considered. Long-term care involves the wound care, physiotherapy of the remaining part of the finger to maintain range of motion.
Amazing.
Digital block, 3 cc's of Marcaine.
Marcaine is the brand name for the local anesthetic bupivacaine, used here for the digital block to achieve anesthetic and analgesic effect. In a digital block, the local anesthetic is injected near the peripheral digital nerves that supply the digit to numb it.
Pulse 110, BP 135/88 in triage.
Any drug allergies, sir?
2 grams of cefazolin?
As we hinted before, cefazolin is a broad-spectrum antibiotic, specifically a first-generation cephalosporin. It's a first-line IV antibiotic for traumatic open wounds because it covers the most likely skin flora, which are gram-positive cocci like Staphylococcus aureus and Streptococcus. Is fast-acting and safe in emergency or surgical settings.
Ooh, wow.
Here it seems like the proximal phalanx of the left little finger has been severed. We can see the bony part of the proximal phalanx still present. A digital tourniquet has been placed distally to stop the ongoing bleeding.
Go with the block.
You ready?
Mm-hmm.
Pinprick and some burning. Where's the missing piece of skin?
It's, under a 1,000-pound unit. It's flat as a pancake.
This means reimplantation is not possible in this case as the severed part has been damaged.
Well, then we have nothing to reattach. Plan, Dr. McKay?
Bone rongeur V-wife.
A bone rongeur is a surgical instrument used to trim or remove small piece of bone. It is used to smooth sharp bone edges at the amputation stump. It prevents bone spurs and soft tissue irritation and helps prepare the stump for soft tissue coverage with flaps. A VY advancement flap is a plastic surgical technique used to close soft tissue defects by advancing tissue forward. It's used when there isn't enough skin to cover the bone or stump after debridement. Here, a V-shaped incision is made. The skin is advanced forward and the wound is closed in a Y shape. This helps to preserve length, function, and sensation of the finger, and hence is often used for fingertip amputations with exposed bone like in this case.
Flap. Exactly.
Awesome, I picked the right case.
Can somebody translate?
To close the wound, we're gonna trim down the bone, then use a plastic surgery trick so the skin will cover everything.
Okay.
Your finger's gonna be a little shorter, no nail.
It's expected as there would be only skin covering the stump.
Great. 10% off manicures. Looks like they found you guys a new rig.
Nah, we Ubered.
Willie Alexander, 81, near syncope from the Memory Day Center. They said he's more altered than usual.
Near syncope refers to transient self-limited episode of lightheadedness, weakness, or dizziness with a sensation of almost fainting without actual loss of consciousness.
Pulse is 30, BP's 80/40. No change with a mig of atropine.
A pulse of 30 beats per minute and BP 80/40 is severe bradycardia with severe hypotension, which is a medical emergency. Atropine is an anticholinergic. This means it can reverse bradycardia if it was caused by vagal suppression of SA and AV node. If it's not the case, atropine doesn't work. Hence, the bradycardia here is unresponsive to atropine's vagolytic action. The possible causes of this bradycardia could be complete heart block, inferior wall MI, or even drugs like beta blockers or calcium channel blockers or digoxin or even hyperkalemia.
He's got a pacer in his chest, but there's no capture.
If the patient has a pacemaker in place but there's no capture, and he's bradycardic and hypotensive with no response to atropine, this is a case of pacemaker failure. Failure to capture means the pacemaker is firing and you'll see pacing spikes on ECG, but it's not causing myocardial depolarization, hence no P or QRS following the pacing spikes. Possible causes of pacemaker failure could be lid displacement in myocardium, lid dissociation from the pacemaker, battery depletion, electrolyte disturbances, especially hyperkalemia, acidosis, or exit block. Here we gotta start transcutaneous pacing immediately and administer dopamine or epinephrine infusion to support perfusion. We also have to assess the pacemaker with device interrogation by the electrophysiology team as soon as possible.
How you feeling, Mr. Alexander?
Call me Willie. I'm fine.
Any chest pain?
No, man.
To rule out myocardial infarction, especially inferior wall MI as hinted earlier, which is caused by blockage of right coronary artery, the same artery which also supplies the SA and AV node and could lead to sinus bradycardia and AV block as well.
Do you take beta blockers?
Drugs like beta blockers, calcium channel blockers, or digoxin could cause bradycardia as they effectively function to decrease SA node firing and AV node conduction, potentially causing sinus bradycardia and AV blocks. However, this is a case of pacemaker failure causing severe bradycardia, hinted by pacemaker in place with failure to capture.
I take walks every day.
Only med is Namenda.
Namenda is the trade name for the drug memantine, which is a NMDA receptor antagonist. As we know, glutamate is a neurotransmitter responsible for brain functions like memory and learning. NMDA receptors are a type of glutamate receptor that, when overstimulated, can lead to excessive calcium influx into neurons, which could cause excitotoxicity and neuronal damage and death. And this neuronal damage is implicated in the pathophysiology of dementia in Alzheimer's disease. Memantine binds to the NMDA receptor at a specific site, preventing excessive glutamate from activating the receptor and causing excessive calcium influx and neuronal damage. By regulating glutamate activity, memantine can help improve cognitive functions like memory and attention. Hence, they are used to improve dementia and slow or delay the progression of dementia in Alzheimer's disease.
On my count, 1, 2, 3.
Pacemaker patient with dementia. Heart rate at 30, little altered with a systolic at 80.
What's your plan, Dr. Langdon?
Second MIG of atropine now. Push dose epi 0.1 milligram portable chest.
Here, atropine is being retried, but would likely be ineffective if it's a pacemaker issue and has nothing to do with vagal overstimulation causing bradycardia. As we said before, we gotta administer dopamine or epinephrine. This is an appropriate ACLS step as the patient's BP is crashing, and we need immediate BP and heart rate support while preparing for transcutaneous pacing, which is emergency external pacing, using defibrillator pads in pacing mode as a fast, temporary, and life-saving procedure done before a transvenous pacing and before the actual pacemaker issue is fixed. Epinephrine causes sympathetic activation and increases heart rate, contractility, and conduction via beta-1 receptors. It also causes vasoconstriction via alpha-1 receptors, leading to increase in blood pressure. Epinephrine 0.1 milligram IV bolus is usually given. This can cause temporary hemodynamic improvement and helps to buy time before the actual cause, that is pacemaker failure, is addressed. Once stable, we could transition this to infusion later with 2 to 10 micrograms per minute. Meanwhile, portable chest x-ray is ordered to evaluate pacemaker lid positioning or associated complications like lid dislodgement, lid fracture, or device migration. We could also start transcutaneous pacing and also send lab tests for potassium, while also informing the electrophysiology team for pacemaker device interrogation.
31 on the monitor.
Dr. Javadi, what do you think of that heart rate?
It's not beta blockers, so junctional escape rhythm?
A junctional escape rhythm is a backup rhythm that originates from the AV junction, including AV node and proximal bundle of His, when the SA node fails to fire, or impulses don't conduct through the AV node. Here, since the pacemaker is present but there is no capture, the ventricles are being paced by the AV junction as a last resort escape rhythm because both the SA node and the pacemaker have failed to initiate an impulse. Here, in this rhythm, the P waves are absent, inverted, or appear after QRS called as retrograde conduction, and the QRS is narrow. To put it into simple words, here the SA node, which is the natural pacemaker, is suppressed, hence pacemaker was put in the first place, that pacemaker is firing, but due to some issue, the heart is not responding to it, so the lower pacemakers like the AV junction take over. The AV junction now fires an escape rhythm to prevent the absence of heart rhythm or a systole, and that's what is being observed right here in this particular case.
Exactly, common with a non-functioning pacemaker. Etiology, Dr. Mohan?
Dead battery or lead failure?
Going a bit deep into pacemaker failure and its causes, we gotta first understand the main types of pacemaker failure. Failure to pace, where there is no pacemaker spike when there should be one. Failure to capture, where pacemaker spike is seen, but no P or QRS follows, like in this case. Or failure to sense, where pacemaker fires at the wrong time, leading to misplaced spikes. The causes of pacemaker failure could be hardware or mechanical issues, electrical issues, or metabolic causes. Hardware or mechanical issues include lid dislodgement, where the lid wires are dislodged from myocardium, lid dissociation, where the lid wires are disconnected from the pacemaker, lid fracture or insulation break or battery depletion, or malpositioned lids or Twiddler syndrome, where the patient rotates the pacemaker under the skin, leading to lid disconnection from the pacemaker. Electrical issues would include exit block, where the pacer fires, but myocardial tissue doesn't depolarize due to, for example, lid electrode issues, increased pacing threshold, for example, due to fibrosis at lid tip, lid impedance being too high or low, or myocardial scar, which could be post-MI. Metabolic or pharmacologic causes include hyperkalemia, severe acidosis, hypoxia, antiarrhythmic drugs like amiodarone, calcium channel blockers, beta blockers, or digoxin toxicity. There could be patient factors or programming factors too, besides all these.
Indeed. Good squeeze, even if it is slow.
Atropine and epi on board.
What's next, Dr. Langdon?
We can try percutaneous pacing, but eventually you'll need transvenous.
Percutaneous or transcutaneous pacing is a non-invasive emergency external pacing using adhesive pads on the chest and back connected to a defibrillator. It's used as an immediate initial step in pacemaker failure before transvenous pacing can be placed. Now, transvenous pacing is an invasive procedure where we place a pacing catheter through a central vein, like the internal jugular or subclavian, into the right ventricle. This provides more reliable, adjustable, and longer-term temporary pacing. It's used before the actual pacemaker issue is fixed. So, usually, when there is immediate unstable bradycardia with no pacemaker capture and no time for central line, we start with transcutaneous pacing for rapid temporary support. Once the patient is hemodynamically stable and central line can be placed, we switch to transvenous pacing as soon as possible for more effective and sustained pacing.
Agreed.
Systolic's up to 95 with the epi.
It's too low.
Let's start a drip, 2 mics per minute.
Here, the blood pressure has improved, but the patient still requires inotropic support. As we said before, after bolus, epinephrine is transitioned into an infusion with the dose of 2 to 10 micrograms per minute.
Check the mental status.
He knows his name. Sir, do you know what year it is?
So, he does know his name. The orientation with respect to person is intact. Here, she's assessing the orientation of the patient with respect to time.
It's 20-something.
Do you know where you are?
Checking the orientation with respect to place here.
It looks like a hospital to me.
Pittsburgh Trauma Medical Center.
Yep, I know this place.
The patient has intact orientation with respect to time, place, and person, indicating that the altered mental status has likely improved.
This Dr. Adamson's place. Where's he at? He working today?
You feeling any pain?
No, that shot worked great.
Like this?
This is the bone rongeur, which was hinted earlier, used to trim bone and also smoothen and sharpen its edges at the amputation stump. This way it shortens the bone so that the skin flap can easily cover it, and also prevents formation of bone spurs and irritation to the flap that would cover it.
How far down?
Just so the sub-Q will cover.
Trim the bone only as far as needed to ensure the overlying soft tissue, especially subcutaneous tissue, and skin can close it without tension. Tension-free closure is a must, as you don't want skin breakdown and wound dehiscence or ischemia at the wound edges later.
You'll need to take a few days off work, sir.
Good, more time to study.
For what?
Master's degree, psychology.
No good.
Yeah. HVAC's just my day job. I went to trade school because I couldn't afford college. Now I can.
Good on the Roger. Working the surgical borders, 2 incisions.
So, a V-shape has been marked as the surgical borders. Here, in a VY flap, a V-shaped incision is made first. The resulting triangular flap is advanced forward to cover the defect. Then the flap is sutured in place and the final closure looks like a Y shape. If the skin is directly pulled to cover the defect, it would cause too much tension and the flap would break or become ischemic and die. VY flap technique minimizes this tension.
Advance the triangle to cover the tip.
Until the V becomes a Y? Exactly.
Yeah, this particular triangular V-shaped flap is to be cut and brought forward to cover the stump. Now the bottom apex of the V-shape would become empty since the flap is advanced forward. The edges of this apex of the V are sutured with each other and hence the V becomes a Y.
I guess you're the boss here?
Something like that.
Very good at teaching. Seriously, you step back and with a few words you impart wisdom.
If you say so.
You mind if I ask what you do when you don't work?
Sleep.
That's a good answer to the patient as a doctor in such cases, and a true one as well. Residents have the least amount of sleep. Where I was an intern, the residents, especially in medicine and surgery, used to have the least amount of sleep and were still operating fine, juggling with the stresses of duties and academics.
Now blunt dissect to undermine the tissue.
What do you think, Dr. Javadi?
3rd degree. Complete heart block.
An atrioventricular or AV block is a conduction defect where electrical signals from the atria fail to conduct properly to the ventricles via the AV node or the His-Purkinje system. 3rd degree or complete heart block means the P and QRS are completely dissociated, meaning that the atria and ventricles are not communicating. Typically, both P and QRS would be present, but they have no relationship with each other, meaning the atria and ventricles are firing independently. In this particular case, the patient's SA node has failed. The pacemaker is failing to capture, so it can't help, and the AV junction is rescuing the heart by firing on its own, hence the junctional escape rhythm. So, the ECG would have no P wave, as the SA node is not firing, and narrow QRS due to junctional escape rhythm originating from the AV junction with a slow rate of just 30 or so, consistent with junctional escape rhythm. Also, there are pacer spikes but no P or QRS afterwards, suggesting failure to capture where the pacemaker is not triggering contractions in myocardium. However, it's mentioned that the ECG now reflects third-degree heart block, meaning the P waves are present with atrial activity. However, the signal isn't transmitted to the ventricles via the AV node, and the ventricles are still relying on escape beats. So, there is essentially no relationship between the P and QRS complexes present, hence a third-degree heart block.
Because?
EV dissociation. No relationship between the P waves and the QRS complexes.
Clear.
Heart rate is 30. This low BP is going to make him a lot more confused.
Could cause a heart attack or a stroke if we don't fix it.
So the low BP causing stroke or myocardial infarction is interesting. Stroke can mostly occur from hypoperfusion. Since there is very low cardiac output due to heart rate 30 and hypotension, this leads to lack of blood supply to the brain. Now in this case of ischemic stroke caused by hypoperfusion, this especially affects watershed areas of the brain between the major vascular territories and can result in bilateral weakness and altered sensorium due to infarcts. Interestingly, bradycardia can allow blood to pool in the atria or ventricles. This blood stasis promotes thrombus formation, which can embolize to cerebral circulation and cause embolic stroke too by blocking cerebral arteries. This is more common in atrial fibrillation, but is very much possible in very low flow bradyarrhythmic states too. Myocardial infarction typically results from supply-demand mismatch. It's called type 2 MI, which is different from the usual one caused by atherothrombotic plaque rupture in a specific coronary artery branch. Here, since there is critically low cardiac output, the coronary arteries may themselves be underperfused too. Now, as the myocardial oxygen demand exceeds oxygen supply, there would be ischemia and infarction, particularly at risky areas that may already have narrowed coronary arteries supplying them. Another interesting thing is that this could not only cause MI, the MI itself, especially inferior wall MI, could actually be a cause of such bradycardia, as the right coronary artery supplying the inferior wall is the same artery that supplies the SA and AV nodes too.
Oh, well, mystery solved.
The wires aren't even touching.
Totally disconnected.
The chest x-ray shows the pacemaker generator, the box which is seen in the left upper chest area in its normal location. However, the wires or lids aren't connected to it and appear displaced, so there is lid disconnection from the pacemaker. Here, the pacemaker is generating impulses but cannot deliver stimulus to myocardium because it simply doesn't communicate with the heart tissue since the wires are disconnected. This leads to failure to capture. As discussed before, the ECG shows pacing spikes, but no P or QRS follows after that.
Shit happens.
Heart rate still in low 30s, no change with atropine.
Pacing pads are on.
We can try.
Placing the pacing pads means they are initiating transcutaneous pacing, the fastest temporary way to try to get the heart to beat when the intrinsic rhythm is too slow. It buys time, while more definitive measures like transvenous pacing or fixing the pacemaker issue are to be planned and prepared for. It's non-invasive, meaning it's done externally by placing large adhesive pads on the chest and back. Basically, defibrillator pads are used in pacing mode. Then an electrical current is delivered through the chest wall to the heart. The goal is to stimulate ventricular depolarization and create a QRS, and hence bring back the heart rate.
Willie, your pacemaker isn't working.
We gotta fix it.
We're going to try to pace your heart from the outside. You might feel it in your chest. Let's start at 10 milliamps, rate of 60.
The typical starting rate for transcutaneous pacing is 60 to 80 beats per minute. It's usually started at 60 BPM, then adjusted based on the response. We are aiming for the electrical capture on ECG, which means pacing spikes followed by QRS, along with the mechanical capture, which means the confirmation of pulse. The output in milliampere is the electrical current given to stimulate the heart, which is started here at 10. It's slowly increased until capture is seen. Capture threshold refers to the minimum milliampere needed to consistently cause ventricular depolarization and QRS. Usually 50 to 100 milliampere is needed in adults. We must confirm both electrical capture with QRS on ECG and mechanical capture with palpable pulse matching the paced rate to confirm successful transcutaneous pacing.
Pacer on.
Oh, twitch it.
No capture.
Increase to 20 milliamps.
That's more like a shock.
The electrical current passes through chest muscles and skin, causing intense muscle contractions with every pacing impulse. Patients describe it as burning, cramping, or jolting. Pain management is important here, usually achieved with opioids and sedatives.
Still no capture.
Up to 30.
Oh, y'all trying to electrocute
Pacer off.
me?
Can't tolerate it.
so the transcutaneous pacing has been discontinued after 30, stating the patient can't tolerate it. Nevertheless, there was no capture, meaning no QRS on ECG was seen, with no pulse confirmation. Regarding tolerance, transcutaneous pacing is very painful, especially in conscious patients, so pain and sedation is usually done with IV fentanyl and midazolam.
Look at this shit!
Dr. Langdon?
One of Versed.
Versed is the trade name for midazolam here.
We set up for Transvenous?
I was set up before he got here.
Typically, failure of transcutaneous pacing would be the indication for transvenous pacing. As said earlier, transvenous pacing is a temporary pacing method where an electrode-tipped wire is inserted through a central vein like the internal jugular or subclavian or femoral and advanced into the right ventricle, delivering electrical impulses directly to the heart muscle. The wire is connected to an external pulse generator which controls the rate and output. It's more effective and less painful than transcutaneous pacing, especially for conscious patients, and buys additional time until the permanent pacemaker issue is fixed, and it's back again.
We're set on board.
Willie, we need to float a temporary pacemaker from your neck into your heart.
Sounds like it's going to be the internal jugular vein for central venous access.
Why is that?
Because your heart rate is only 30.
And hit me with a shot of atropine.
You've already had 3.
Atropine didn't work as it's not a case of vagal suppression of heart rate. Epinephrine is being infused and hopefully it would take care of the heart rate eventually, or would it not? Let's see.
Wait, are you a doctor?
He's out.
Looks like the patient went unconscious due to the low cardiac output causing cerebral hypoperfusion, severe enough to cause syncope.
Ginger, what do you think about having some help at home?
I think Rita could use a little break every now and then.
We can't afford it.
Oh, Kiara told me about DHS Senior Phone Line. It's part of AAA, the Area Agency on Aging.
The Area Agency on Aging is an organization in the U.S. that provides support and services to help older adults, typically age more than 60, to live independently and safely in their homes and communities. It provides Meals on Wheels or congregate meal programs, home care services like bathing, dressing, or housekeeping, caregiver support, along with providing transportation to medical appointments and help with Medicare or Medicaid.
They make referrals for in-home services.
What's that going to cost?
Medicare will cover short-term home care, at least 10 hours a week.
Ginger, have you ever been to a senior center?
I went once. Nothing but old people.
AAA also has senior companions for a few hours a day, and if Rita needs to be away at lunchtime, the Options program can deliver a meal.
Sounds like a good deal for the caregiver, too.
Is everything all right? Yeah. Did I say something that upset you?
No, it's all good. It's just... This is way more than I expected.
This could definitely provide some downtime to the caregiver for herself.
Bam. Internal jugular accessed?
Pulse ox 99 on 5 liters, systolics 95 on epi.
That's good enough to perfuse the brain.
Typically, transvenous pacing is done once the patient becomes somewhat hemodynamically stable. During transvenous pacing, hypotension could worsen due to sedation or the line placement, and this could cause cardiovascular collapse and further cerebral hypoperfusion. So here the BP has improved a little with epinephrine, just enough for cerebral perfusion, so we can safely start central line for transvenous pacing. That's why we try transcutaneous pacing before that as an initial step when the patient is not stable, only to be followed later by transvenous pacing when the BP has somewhat improved after providing inotropic support with dopamine or epinephrine.
Good work.
You doing okay under there, Willie?
I guess.
This is an ultrasound guided central catheter placement. First, a needle is used to puncture the skin and enter the targeted vein via ultrasound guidance. Once the needle is confirmed to be within the vein, the guide wire is passed through the needle's lumen and advanced into the vein. The needle is then carefully withdrawn, leaving the guide wire in place.
So this is just like a triple lumen?
There is a lot of difference in these two procedures. First, a triple lumen central venous catheter can also be placed in the same site in the internal jugular vein, but is used for infusion, monitoring, and blood draws. In this procedure, after the guide wire is in place, the dilator is passed over it to enlarge the passage, then it's removed, and then the catheter is passed over the guide wire and advanced all the way with its tip reaching the superior vena cava or right atrium. An introducer sheath, on the other hand, is a large bore catheter. It has a single large lumen to accommodate the pacing wire. In this procedure of transvenous pacing, after the guide wire is in place, the combined introducer sheath and dilator is passed over the guide wire, and the dilator is removed along with guide wire, leaving only the sheath in place, accessing the jugular vein. Finally, the pacing wire is inserted through the sheath and into the vein, all the way through the right atrium, then across the tricuspid valve into the right ventricle. Its distal tip has an electrode, which is used to deliver electrical impulse to the right ventricle myocardium from the external pacemaker box connected to the other end, resulting in a QRS complex that is ventricular depolarization.
Except you need a big 7 French introducer to fit the pacing wire.
So this is the guide wire which is being advanced through this introducer needle right here. I guess the scene tried to show the introducer needle being removed by holding the guide wire still. The introducer needle is still there being held by him, which is to be removed, before advancing the dilator with sheath, removing the dilator and wire, and then advancing the pacing wire through the sheath.
I could use some air.
Is that any better?
What y'all doing?
We're putting a temporary wire into an external pacemaker until you can have surgery to repair the one in your chest.
As said before, this is to buy time for the definitive fix of the pacemaker issue which requires surgery.
Heart rate's still 31.
Bradycardia.
How does he know the word bradycardia and also recommend himself a dose of atropine earlier? He could be from the medical field.
Are you a doctor, Willie?
Yeah, right.
No mention of any medical career in his past records. Just mild dementia.
Oh, you a doctor. That was a good one.
If not in the medical field, he must be a chronic patient to be familiar with medical terms.
Okay, last one.
How's it look?
So, this is the Y shape of the wound after suture, hence called as the VY advancement flap, as a V-shaped incision has yielded a Y-shaped sutured wound, while also covering the amputated stump successfully.
Perfect. Xeroform and tube gauze.
Xeroform is a non-adherent petrolatum-based gauze impregnated with bismuth tribromophenate. It's used for dressing for skin grafts, burns, or surgical wounds, as it provides a moist, antimicrobial environment, prevents sticking to wounds, reduces pain, and helps healing.
What's up, party people? VY flap. Nicely done. Can I borrow Dr. Santos?
As long as Dr. McKay can finish the dressing.
Sure. I can't stop thinking about your foot. You know what I mean. I'm sorry, but I know. Move on. Already did. Okay. There's a high-maintenance surgery clinic patient down here, as in total pain in the ass.
High maintenance means the patient demands excessive time or attention from the surgical team or frequently complains or worries, even if the situation or condition is minor.
I could use your help distracting her. So we're good. Every hero needs a sidekick.
I need to find a tube gauze cage. I'll be right back. You'll need to elevate antibiotics 3 times a day for a week. A couple of painkiller tablets, but try to get by on Tylenol and ibuprofen.
He would likely be put on broad-spectrum antibiotics like cephalexin and pain meds like acetaminophen and ibuprofen. If the pain is too much, the grade of pain meds could be increased, but it's better to stick to the simple ones for less side effects.
Are you okay? Is today a bad day?
Drowning victim, ETA 3 minutes. Sorry, I gotta go.
20 centimeters clears the cordis.
This means that he has the cordis introducer sheath inserted into the right jugular vein, and now he is passing the pacing wire through it. The pacing wire has been advanced 20 centimeters from the skin entry point, and that length has now passed beyond the cordis introducer sheath.
Pacing box rate of 85 milliamps.
Confirmed on ventricular setting.
The rate for the pacemaker is usually 60 to 80 beats per minute, with the current output starting from 5 milliampere and titrated upward accordingly to capture.
Passing to 30 just outside the heart.
This means the pacing wire is 30 centimeters deep and is still just outside the heart. The length from skin point entry to the right ventricle is usually 20 to 35 centimeters.
Why do we inflate the balloon now?
So it'll float into the right ventricle.
The balloon is inflated to allow the catheter tip to float with blood flow and avoid traumatic injury to the endocardium. The balloon helps use the bloodstream like a river, carrying the catheter tip forward into the right heart without trauma, hence it's called a flow-directed catheter. This provides a safer, less traumatic route to the right ventricle. Once the catheter is in position, the balloon is deflated. We should never leave it inflated during pacing because there is risk of perforation of cardiac tissue, cardiac tamponade, and interruption of pacing contact.
Exactly. We're looking for
An injury pattern since it's below the AV node.
When placing a transvenous pacing catheter, we're aiming for a position in the right ventricle, most often the apex or the septum. This position is below the AV node in the electrical conduction system. We can observe here that the heart rate has jumped to 80, as was the rate provided by the external pacemaker. This means there has been electrical capture. This means the pacing stimulus is triggering depolarization of the ventricles, as seen on ECG, as every pacing spike is followed by a wide QRS complex. Even the blood pressure has improved. Now, we gotta confirm mechanical capture with a palpable pulse, matching the paced rate.
Looking good. Check the pulse.
strong reading, really strong.
This confirms mechanical capture too. This means the transvenous pacing has been successful and would take care of the hemodynamics till the permanent pacemaker issue is fixed via surgery.
Man, I feel like I just woke up.
Nice work, Dr. Langdon.
Systolic's up to 130. How do you feel?
Yeah, like $1 million. Widen QRS on the scope.
Widened QRS after each spike is a characteristic feature of transvenous pacing. As the electrode is placed on the right ventricle, the ventricular depolarization spreads slowly through muscle cell-to-cell conduction instead of the normal rapid conduction via His-Purkinje fibers. That's why it results in a wide QRS complex, often resembling a left bundle branch block pattern on ECG.
Willie, did you used to work at this hospital?
Hell no. I just brought the mail.
Can we still Javati?
Absolutely.
Time to shine, Crash.
Do you have time to write the procedure note?
Oh, the procedure notes. That takes a lot of time to write, especially if there are multiple procedures, especially if you're in surgical specialties.
No problem.
I'll be at Central if you need me.
Oh, geez, I still need to tell Nandi about her mercury level.
The average emergency doctor gets pulled from task A to task B every 3 to 5 minutes.
Remind me again why we picked this specialty?
Because we all have ADHD and anything else would be boring as hell.
Yeah, the variety of cases an emergency doc would see from almost every specialty is second to no other specialty. It does have its own pros and cons. The pros being that we can see lots of different cases in a single shift. The cons is that we gotta know so much and even more, and the craziest of the craziest cases in the hospital almost always land up in emergency first.
May have another ICU admission. I'll call to confirm. Okay.
Dr. Collins, do you think that we might be able to...
Drowning victim here. Not right now.
Amber Phillips, 6 years old, found at the bottom of a home pool with an unknown downtime. Asystole on the monitor.
Meaning the child has already gone into cardiac arrest, a non-shockable one in a systole, which basically means a flatline ECG. CPR and epinephrine IV every 3 to 5 minutes is the way to go.
Intubated with a cuff 4.5, 22 gauge left AC, 0.25 epi 3 minutes ago.
1, 2, 3. We're gonna take over compressions. Any family coming in?
Grandma and little sister.
Fast and deep.
Ready?
Yeah, go.
She's really cold.
Okay, you gotta get a cord tip.
So basically, the child is intubated, the ambu bag ventilation is being given along with chest compressions. Epinephrine has also been given, maybe repeat epinephrine since it's already 3 minutes.
Big breath sounds bilaterally.
Should we use the Lucas?
No, she's way too small for that.
The Lucas is a mechanical chest compression system is used for performing consistent CPR during cardiac arrest. The age considerations for Lucas is that it is typically indicated for adults and adolescents, generally aged 8 years and older. Some sources even say adolescents over 30 kg. It's not routinely recommended for small children or infants due to their smaller chest size and different chest compliance, which may not fit the device properly or risk further injury than benefit.
Rectal temp only 85.
What do you think, Mel?
She's cold, moderate hypothermia.
Hypothermia means a core body temperature less than 95. Moderate hypothermia is when it's between 82.4 to 89.6. This needs active rewarming and careful monitoring.
We need to get her up to 90 if we have any chance of restarting her heart.
250 cc's heated saline. Set up the Arctic Sun.
The Arctic Sun is a medical device used for controlled therapeutic cooling and warming of patients. It's a non-invasive temperature management system and uses cooling or warming pads placed on the patient's skin. It circulates temperature-controlled fluid through these pads to regulate core body temperature.
Continuous core temp monitoring and prep another epi 0.25.
Yep.
Preemptive order's done. Let's go.
I don't understand why you need me.
Crohn's disease status post-colectomy 10 years ago, now with severe abdominal pain.
Crohn's disease is a type of inflammatory bowel disease that can affect any part of the GI tract from mouth to anus. Colectomy means removal of the colon, the large intestine. Crohn's often affects the terminal ileum and could extend into the colon. Even after colectomy, disease can persist or recur in the ileum. Now, the possible causes of severe abdominal pain, 10 years post-colectomy, could basically be disease recurrence in the small bowel, commonly ileal or jejunal involvement. It could be complications like formation of strictures, meaning narrowing of the bowel lumen, causing obstruction. There could be different types of fistula formation where the diseased part of the bowel could communicate with another part of bowel, urinary bladder, and even skin. There could be abscess formation. Adhesions causing bowel obstruction could be a common occurrence, especially post-surgery. There could be ischemia and perforation with peritonitis, which is a surgical emergency.
Could be perforation, fistula, obstruction. Great teaching case.
Someone give me something for the pain!
Good afternoon, Miss Walker. I'm Dr. Garcia from surgery. This is Dr. Santos and Javadi. It's like you're in a lot of pain.
No shit!
We ordered you some morphine.
Morphine can be used for severe abdominal pain, but with caution, especially in cases like suspected bowel obstruction or perforation such as in Crohn's disease. It could cause gastrointestinal smooth muscle spasm and cramps. IV acetaminophen or ketorolac may be used in milder cases if RFTs are normal. Hydromorphone is sometimes preferred in Crohn's flares because it causes slightly less smooth muscle spasm than morphine.
Did you read my chart? I'm allergic to morphine! I'll puke my guts out!
That's a side effect, not an allergy.
Give me some Dilaudid.
Okay, 1 milligram Dilaudid.
So morphine stimulates the chemoreceptor trigger zone and also causes more histamine release, as a result of which it causes more nausea and vomiting. The same histamine release is also responsible for it causing more abdominal cramps due to GI smooth muscle spasm, as we said before. Hydromorphone or Dilaudid, on the other hand, though being about 5 to 7 times more potent than morphine, causes less histamine release and hence is less emetogenic and also causes less abdominal cramps due to spasm.
I'll grab it from the PDS.
One is never enough. I need 2, sometimes 4.
Got it. Pertinent history, Javadi.
Have you had any fever or vomiting?
Oh, shut up with your question.
Yeah, patients groaning in pain won't be giving proper history unless their pain is in control.
Man, we can't help you.
Well, if you want to help me, give me my doctor. Dr. Shamsi. 10 years, no one knows me better. I don't want to talk to anybody else.
I'm very sorry, but she's in surgery right now.
Oh, that's why they called her in.
How long?
Unknown.
Oh.
But ma'am, right here we have Dr. Shamsi's daughter, Victoria. She's the next best thing.
Time for another epi.
Here, we are looking for any signs of return of spontaneous circulation, whether it's a palpable pulse or a sinus rhythm. CPR and epinephrine every 3 to 5 minutes are to be continuously given, and after 20 to 30 minutes of good CPR and epinephrine, with all the reversible causes addressed, if there is still no signs of life, rhythm still remains asystole with no pulse, no respiration, and no cardiac activity, no shockable rhythm, with fixed dilated pupils, the patient is declared dead. However, special circumstances merit longer resuscitative efforts. In case of hypothermia, we often say no one is dead until they're warm and dead. We continue CPR until core temperature is more than 90. Also, in pediatric patients or in cases of drowning or drug overdose like opioids, we often extend CPR.
Dr. Robbie.
Be right back.
My wife and I decided we're on board with organ donation.
Oh, I'm really glad to hear it.
The church supports their decision.
The OPO is sending an ambulance.
I'll be staying with the family.
This shows that it's always important to provide time to parents to think about important decisions surrounding their child rather than rush to talk about them while they're simultaneously in shock about the loss of their child.
How's it going in there?
Oh, not good.
Robbie. For the little girl in trauma 1, this is Grandmother Frances and Sister Bella.
Hi, I'm Dr. Rabinovich.
How is she?
Taking the young children away before delivering bad news is important to shield them from immediate emotional trauma. Children aren't developmentally ready to understand or process death, so sudden grief reactions from adults like screaming and fainting can deeply traumatize children.
Bella, would you like to color? Maybe get a snack?
Yes, please.
My name's Kiara. Let's find you some crayons.
I like to draw.
Let's do it. Come on.
They are still doing CPR.
Can I please see her?
Yes, of course. Got Grandma coming in. You sit right by the bedside.
Ready to switch?
Go.
Bringing the family member in to see in the last stages of a patient's life is an increasingly recognized and supported practice in many hospitals. It's called family witnessed resuscitation. It helps the family member grasp the reality. Seeing the efforts being made gives them a clearer understanding that everything possible was done. This could also help them in their grieving process. They can feel a sense of closure or comfort, especially if they can hold the patient's hand, speak to them, or be present in their final moments. Studies also suggest that this reduces long-term psychological distress like PTSD, anxiety, and complicated grief compared to those who weren't present during resuscitation. Most importantly, it builds trust as they witness the clinical team's effort and observe that the patient was cared for till the very end.
Here you go, ma'am.
You can hold her hand.
We can allow them to stand at a safe spot away from the team's immediate workspace, allow them to hold hands, and gently explain what's happening.
She wasn't breathing, so the medics put a tube in her throat.
She's so cold.
We're warming her up. That way she'll have a better chance to respond to the medicines.
They moved a bench next to the pool fence so they could go over. Because their soccer ball went in the water. Amber couldn't make it out the deep end. The gate was locked. I was vacuuming. I didn't hear them.
Seeing your child struggle between life and death has to be one of the most painful experiences a person would ever have to go through.
My mercury level is 94.
That's high enough to cause all your symptoms.
As pointed out before, her condition is likely the result of mercury-induced psychosis, as mercury was absorbed transdermally and it accumulated in the brain, disrupting the dopaminergic and serotonergic neurotransmission and causing psychotic symptoms like auditory hallucinations and delusion of persecution, as seen in the patient. Not only this, it was also responsible for tremors, which would reflect the toxic effects of mercury on cerebellum. It's also called Mad Hatter's tremor or Danbury tremor, as it was classically associated with mercury poisoning, especially inhalational exposure to elemental mercury, which was historically seen in workers in hat-making industries in Danbury, Connecticut. These are intention tremors as they worsen with purposeful movement, like when reaching for something. Other features of Erethism or Mad Hatter syndrome would be emotional lability, irritability, insomnia, memory and concentration issues, personality changes, and peripheral neuropathy, along with psychosis, all of which are relevant in this case.
Insomnia, tremors, imbalance, psychosis.
From a stupid face cream.
We're gonna start chelation therapy.
She's going to receive DMSA or dimercaptosuccinic acid, which is a chelating agent used for heavy metal poisoning cases like mercury, lead, or arsenic. It binds the metal ions, mercuric ions in this case, and helps form stable complexes with it, and these complexes are excreted via urine. This would decrease its serum levels and potentially improve her symptoms, or at least not worsen it or prevent progression.
It's a medication that binds with the mercury and helps your body excrete it.
And then I'll be back to normal.
I don't know. Are any of us normal?
That's an indirect way to say the toxic effects of mercury on her brain, which has already occurred, could never resolve. It probably would not progress from the present state.
Where's my phone?
They locked it away with all your valuables.
I need my phone.
Okay, but when you post, you have to tell everyone not to use the cream.
Definitely. Can I borrow your phone? Just the camera. I was wearing a wig when I left my apartment. I had a wig when I came in, right?
Not when you came in.
Oh my god. I look like shit.
she's still more concerned about how she looks, rather than the gravity of her illness due to the products she used for her looks.
How is he doing?
Stable. Scheduled for a new pacer tomorrow with cardiology.
So they're going to remove the pacemaker and install a new one via surgery. Surgery to place a new pacemaker would be indicated in several causes, including device malfunction. I guess the relevant one here would be if the pacemaker's header port becomes damaged and can't secure leads, and hence the leads are seen disconnected.
Great.
Robbie, here at the T1. This is Dr. Robbie.
Where's Amber? Is she okay?
What have you heard?
She got pulled from the pool.
She wasn't breathing, so we're doing that for her now, and we're trying to get her heart started again.
Wait, her heart stopped?
I have to be with her.
Of course. There are a lot of people in here right now trying to help her.
This is again adding to the family witnessed resuscitation discussed earlier. Being with your loved one till their final stages when they're being resuscitated definitely does help the family members to grieve, while also being ensured that everything that could be done was done by the medical team.
I understand.
Amber. Oh my God, Amber. I love you. I love you so much. I am so sorry. Where's Bella?
She's with our social worker.
Oh, I should be with her.
I'll go with you, Mom. I'll be right back.
Come on, she's still in the hall a bit. Hang on, we got it.
Oh.
Rhythm check, hold compressions.
We hold chest compressions for rhythm checks, which typically occur every 2 minutes during the pause to analyze rhythm. The pause should be less than 10 seconds. Chest compressions create too much electrical artifact on ECG while they are ongoing. That's why pauses are needed, but they must be very brief, or else survival worsens due to interruption of blood flow to the brain if the pause is longer.
Asystole. Resume compressions.
3 minutes since the last epi.
Push another.
Did you shock the heart?
No.
Why didn't you shock the heart? We've got to save her. You got to shock the
Cardiac arrest rhythms are classified as shockable and non-shockable. Shockable rhythms that could be potentially reverted into sinus rhythm with the help of defibrillator shock include ventricular fibrillation and pulseless ventricular tachycardia. Non-shockable rhythms that can't be reverted with defibrillator shock include asystole and pulseless electrical activity. So, the only measures left at this point would be CPR and epinephrine, both of which are being carried out here.
Heart rhythm right now is flatline, and that's not treatable with a shock. We're trying to get the rhythm to change to something we can shock by warming her up.
We can hope that with CPR or by treating hypothermia, either the heart rhythm would restore back to normal sinus rhythm, or at least it could convert into shockable rhythms like VFib or ventricular tachycardia that can then be potentially reverted back, or hope for these favorable changes to occur by treating the hypothermia.
Okay, so we got to warm up. We got to get some more blankets in here or something.
We're giving her warm IV fluids, and you can feel these blue pads. They have warm water running through them like a hot tub.
Here, the parent, by being there at the moment, can acknowledge that every possible effort has been done to resuscitate her child. Also, she now has a better understanding of what's happening and what to expect. This way, it helps her to face the reality, and this tremendously helps in the grieving process and prevent unnecessary ruminating thoughts, guilt, and emotional distress about what could have or couldn't have been done.
Are you sure you're doing everything?
Yes, we are.
Amber, honey, I'm here.
Besides building trust towards the clinical team by seeing their hard work to save her child, she can also feel a sense of comfort as she is there at her final moment with her, something that would decrease guilt later on in the process of grieving.
It's gonna be okay, I promise you. Everything's gonna be okay. I can't take it much longer.
Dr. Shampsy on speakerphone from the OR.
Eileen, how soon can you get here?
I'm finishing a lap chole. Shouldn't be long.
Lap chole means laparoscopic cholecystectomy, which means the surgical removal of the gallbladder via laparoscopy. It's a common surgical procedure usually done for symptomatic gallstones or acute cholecystitis, meaning inflammation of gallbladder.
Your daughter's here.
Hi, honey.
Minimal relief with 2 of Dilaudid.
She needs 4.
That's what I've been telling them.
We're titrating. We didn't want her to stop breathing.
Opioids like morphine or hydromorphone, which is even 5 to 7 times more potent than morphine, are CNS depressants. They could cause respiratory depression at high doses, and this could lead to hypoventilation and apnea.
Is Dr. Garcia with you?
Right here.
How's the exam?
Rigidity with guarding.
Rigidity and guarding are both signs of peritoneal irritation. Guarding means a voluntary tensing of the abdominal wall muscles in response to palpation due to pain or fear during examination. It's seen even with early or mild peritonitis. Rigidity means involuntary, reflex contraction of abdominal wall muscles. This is a sign of advanced peritonitis and indicates severe inflammation. Now, these signs in a patient of Crohn's with severe abdominal pain could very well indicate perforation of the bowel leading to peritonitis.
Sounds like peritonitis. 2 sets of blood cultures and 3.375 of zosyn.
Blood cultures are to be done to rule out the presence of bacteria in blood called as bacteremia, the source of this being peritonitis. Zosyn is the trade name for piperacillin tazobactam, a potent broad-spectrum antibiotic to be given in this case, suspecting sepsis.
Make sure she's next in line for a CT scan, bump everyone else. Do you understand?
We gotta rule out perforation since it's a surgical emergency, hence imaging should be ordered immediately. X-ray abdomen would immediately rule out perforation with air under diaphragm. A CT scan would provide a more definitive and precise diagnosis but takes time.
Victoria?
Got it.
See you soon.
Thank you, Eileen.
Ready for some more dilaudid?
God, yes.
Victoria will make sure all of Dr. Shumsey's orders are followed. Call if you need us.
Yeah.
Great move bringing in Javadi.
Is this patient payback for dropping the scalpel?
Look at the bright side. If she goes to the OR for perf, you can scrub in, I'll coach you.
Perforation is a surgical emergency and requires primary repair of the perforation or resection anastomosis if the bowel segment is damaged enough.
You'll make a brilliant first impression on Dr. Shumsey.
Really? You do that?
Mm-hmm.
Thanks. I have something unusual to ask.
Okay.
I've been on 2 cases with Langdon, and there have been irregularities with benzos. Lorazepam with a seizure, Librium with an alcoholic.
And
I'm concerned.
concerned about what?
That he could be stealing?
No intern would really complain to a resident about another resident or have the guts to, and it's rather uncomfortable to tell, even if your suspicion could be right.
Whoa, whoa, whoa. I insult the shit out of Langdon, but he's a great doctor. I've never seen him impaired.
What do I do?
You've been here for what, 7 hours? Just do your job.
Yeah, this is the response you would be met with if you happen to complain to a senior about another senior.
A weird vibe out here. Yeah, pediatric drowning will do that. Thought I didn't end up in there. Yeah, you and me both.
Any life-threatening pediatric case is difficult to handle emotionally for everyone involved, including both staffs and family members.
I'm off to North 2, dysuria.
Dysuria means burning micturition, a sign of urinary tract infection, which presents additionally with fever and flank pain.
What happened to 2 visitors a patient? It's the fentanyl overdose. It's gonna be an honor walk. He's an organ donor.
An honor walk, also called a hero walk, is a ceremonial tribute given to a patient who is about to donate their organs, usually after being declared brain dead. Hospital staff, family, and sometimes the public line the hallways as the donor is wheeled from the ICU to the operating room. Everyone stands silently with heads bowed in honor of the donor, hence there is a crowd there.
Myrna? Myrna. Oh, no, not today.
She's gonna do the sternal rub to test response to painful stimulus in suspected unresponsiveness.
Myrna! What the f? What do you think you're doing?
I was just checking on you, ma'am.
You can't even take a nap in this hellhole. Off.
Sorry.
She should have just called her by her name first, instead of starting with a painful stimulus. Sternal rub is pretty painful.
Hi, I'm Dr. McKay.
Piper. Laura.
And you guys are...
She's my boss.
Oh, what kind of work?
I'm an accountant and she's my assistant.
Cool. Piper, are you okay with your boss being here while we talk?
Yeah, I'm good.
Are you sure? I'm gonna be asking you some pretty personal questions.
She doesn't mind. We have no secrets.
What does that even mean?
Okay. So burning with urination, when did that start?
About 2 days ago.
Why don't we let Piper answer the questions?
I'm sorry. We've been waiting so long.
Usually an informant isn't needed in history taking of an adult, unless the adult isn't responsive or if the case requires history from the informant.
About 2 days ago.
Any blood in the urine?
Blood in the urine or gross hematuria could be due to urinary tract infection, kidney stones, and even tumors.
I don't think so.
No, she would have definitely noticed that.
Okay. I'm gonna get you a gown and I'll be right back. Okay?
Okay.
Any change with the extra dilaudid?
Not really. The pain is still there.
Acute abdomen with tenderness on palpation along with signs of guarding and rigidity could be a surgical emergency with peritonitis due to perforation.
Sorry, just to review, no fever, no vomiting, no diarrhea, no constipation.
Correct.
But peritonitis would have all these symptoms. Acute peritonitis usually presents with severe abdominal pain along with fever, nausea, vomiting, and changes in bowel habits like constipation or diarrhea. Fever would be expected at least if it was perforation causing peritonitis. Could this be something else?
When exactly did the pain start?
10:15 this morning, all of a sudden.
That's very strange. I agree. Will you tell me everything you did this morning?
Took a shower, had breakfast, some coffee, toast with jam, yard work, moved some firewood.
Did the pain start before or after the firewood?
A little bit after. I might have got a splinter in my foot. I wasn't wearing socks. Other one.
Looks like puncture wound there. How does this possibly explain the abdominal symptoms though?
2 small puncture wounds 1 millimeter apart.
2 splinters.
Whoa.
What?
There's a dead black widow spider in your shoe.
You're shitting me.
Red hourglass marking.
Okay, so this is an interesting twist to the case. The black widow spider is venomous, and its bite can cause systemic neurotoxic effects. It has the characteristic red hourglass-shaped marking, often appearing as 2 triangles joined at their points on the underside of its abdomen, differentiating it from other spiders. Interestingly, this spider's venom can cause severe abdominal cramps, which can actually mimic peritonitis or acute abdomen due to abdominal wall rigidity. This could possibly explain her symptoms, and a CT scan may not be required in this case.
We need IV diazepam. Start with 5, might need 10.
The black widow spider venom contains alpha-latrotoxin, which causes massive release of catecholamines and also release of acetylcholine at neuromuscular junctions. This leads to excessive muscle contractions or spasms, causing muscle cramps, along with other autonomic symptoms like tachycardia, hypertension, sweating, headache, and restlessness. Hence, the main symptoms include severe muscle cramps in chest, back, and abdomen, causing a stiff board-like abdomen mimicking peritonitis. So, apart from wound care and pain control, benzodiazepines like diazepam are the mainstay of treatment, as these act as muscle relaxants to ease the muscular spasms and cramps. Antivenom is reserved for severe or refractory cases and is rarely needed.
What does a spider bite have to do with my Crohn's disease?
Oh, nothing.
Having Crohn's as past history rather complicated the diagnosis and made the doctors think of Crohn's complicating into perforation and peritonitis rather than thinking of other simpler differentials.
Black widow venom can cause muscle spasms in the belly. People have had surgery thinking it was appendicitis.
The black widow spider bite can mimic any cause of acute abdomen, including appendicitis. It could even cause symptoms mimicking tetanus, all of which can be tied to its venom's spasmodic effect.
Hi, Dolores. Why didn't you get her to CT yet?
I don't think she needs it.
Yeah, CT isn't required unless the surgeon would like to assess the progression of Crohn's disease too, in addition to the main diagnosis of spider bite. There is likely no perforation, and it ties to the fact that there is no fever and other GI symptoms.
The abdomen is rigid. She's perfed.
Maybe not.
What are you giving?
Diazepam.
I didn't order that.
I did. She has a rigid abdomen, but no other GI signs or symptoms. It didn't make any sense. There's a black widow spider and a bite mark on the foot. The venom is causing spasm of the abdominal wall musculature.
Whatever you guys gave me, it's working.
Possibly.
No, definitely. I'm much better.
The opioids given before doesn't relax the involuntary muscle spasm caused due to the venom, and hence the pain persists. However, benzodiazepines do cause relaxation of the rigid abdominal muscles and hence has relieved the pain here. Hence, knowing the exact cause of pain and countering it with appropriate medications is much more helpful than a bunch of pain meds given in general to ease pain of any and every sort.
Take a deep breath. Good. Good. You from Pittsburgh?
2 hours north, like Mill Village.
Okay. You have any family you want to call?
I don't have a phone.
She can use mine if she needs to.
Okay. Lay down. I've never heard of Mill Village.
Yeah, nobody has. Population 400.
Wow, that's small.
Tell me about it. After high school, I had to get out of there.
Well, you're lucky you found a job. Any pain around here?
Mm-hmm. A little.
Tenderness in the lower abdomen, I guess. Could be due to cystitis or inflammation of the bladder, relevant with the burning micturition here. Or could be pelvic inflammatory disease or other uterine or ovarian causes.
Okay, sit up for me. You gave us a urine specimen?
Hours ago in the waiting room.
Okay. Well, I'll find the results and then you might need a pelvic exam.
Is that really necessary?
A pelvic exam includes external inspection of the vulva, per speculum examination of the vagina and cervix, and bimanual examination to assess uterus and ovaries and detect any tenderness. It could be useful here to detect cervical motion tenderness, which could be a sign of pelvic inflammatory disease, which means infection of the upper female reproductive tract, including uterus, fallopian tubes, ovaries, and cervix. It could be another differential if UTI isn't the case here.
It could be. If there's no bladder infection, it's important to check.
Okay.
And if we do a pelvic, Laura, we'll have you step outside for a minute.
I prefer to stay with her for support.
That's weird.
Piper, do you want some privacy?
No, it's cool. She can stay.
That's even weirder. Why would you want another person to watch when a pelvic exam is done?
Okay. All right, I'll be back.
Core temp is 88.
Is that good?
So, the core body temperature has been elevated with rewarming, still no signs of return of spontaneous circulation.
It's up from 85 on her arrival, so we're headed in the right direction. You hear that, Amber? It's better. You're getting better.
I need to step out for a second. You're in good hands. Come find me when it's over 90.
The prognosis for the child is poor here. At least the parents here know what's happening and what to expect by being beside the patient the whole time.
Parents are gonna need the family room.
It's available now. Last rights for Nick.
Just one of those days.
Yeah.
Anyone else dying?
Not at the moment.
Where lives are saved, lives are lost as well. This is the nature of the department that is the ER.
What the hell is that?
Hope that's the TikTok informing everyone about the toxic effects of the facial cream and not some random content.
Who asked for better patient satisfaction scores? What do you want, man?
Excuse me, Dr. Robbie. This is Eli, son of Willie Alexander.
Hey, nice to meet you.
Likewise. How's he doing?
He's doing better. He's gonna need to stay with us, though, for a new pacemaker.
He got a new one at Presby about a year ago. They said it'd be good for 10 years.
Yes, but the wire's separated from the box.
As said before, surgery to place a new pacemaker would be indicated in several causes, including device malfunction or end of life, meaning if the pacemaker is not outputting current or has battery depletion. Pacemakers typically last 5 to 10 years. After that, a new generator is implanted. What happened here is that the lids are seen disconnected from the box. Usually, if that's the only issue and the lids are intact and not damaged or dislodged, the lids could be reconnected to the same pacemaker which is intact. Here, we are seeing pacing spikes. This means the pacemaker is working and there is no malfunction. But still, since a new pacemaker is needed here, my guess here is that the pacemaker's header port became damaged and can't secure lids, and hence it has to be replaced. If the lids are damaged or dislodged from their normal tip position in the myocardium, they are to be replaced too.
It happens sometimes.
Can he have a visitor?
Of course, right this way.
Hey, Eli, what did your dad do for a living?
Postal worker, 40 years.
Did he ever do any volunteer work at the hospital?
No, but when he was a kid, he was a medic for the Freedom House ambulance service.
So, that's the reason why he knows and still remembers the meaning of the medical terms. In ambulance service, definitely the terms bradycardia and atropine would be commonplace.
That's incredible. I will be in as soon as I can.
Thank you.
Guy's a legend.
I know.
Sorry, can I get your help with something?
Yeah.
18-year-old woman with dysuria, moved here 2 months ago from rural Pennsylvania. She's with her female boss, who's very controlling and answers questions for her. Won't leave her side for anything, even a pelvic exam.
And you're thinking?
Red flags for trafficking.
Sounds like it.
Interesting observation. The boss likely feared any little thing that the innocent girl would say that could implicate her, hence she couldn't even leave her alone for a pelvic exam due to this fear. Definitely something unusual going on.
We need to take a sexual history and do a pelvic in private. She's not going to talk unless we separate them.
That we can do. Come on.
It looks like ST elevation. That could be bad.
Paced QRS complexes, especially ventricularly paced rhythms, can mimic ST elevation on ECG, but it's actually the widened QRS complex after the pacing spike due to slow ventricular depolarization, since the electrode is placed on the right ventricle and the ventricular depolarization spreads slowly with muscle-to-muscle conduction rather than the normal Purkinje fiber's rapid conduction. That's why it results in a broad QRS complex followed by secondary ST and T changes that might look like ST elevation or depression. But it's not true ST elevation seen in myocardial infarction and is not concordant with QRS.
Oh, no, that's just because we're pacing your right ventricle. Willie, I'm impressed. After all these years, you still remember your medical training.
Well, he couldn't tell you what he had for breakfast.
This reflects damage to recent or short-term memory, while remote or long-term memory is initially preserved in classic dementia seen in Alzheimer's disease. This happens because hippocampus, which is critical for forming new memories, is one of the first areas affected in Alzheimer's. This impairs the ability to encode and store new information. But memories from long ago are stored in neocortical areas and are intact initially, and affected late in the course of dementia. This is particularly called anterograde amnesia, where the ability to form new memories is lost, while past or remote memories may still be intact.
It's all right. I remember what's important, like the Freedom House.
What's that?
Damn shame. That's your history.
Dad, they're busy.
Back in the 60s, no 911, no ambulances. All we had was police paddy wagons that took you to the hospital if you were lucky. Then this doc from Pitt, Dr. Safa, he got some money and trained us up.
Well, you must have been a good student.
Medical knowledge is so volatile, if not repeated enough, it gets lost over time. So it's really impressive to remember little things too of what you learned as a kid, even after several decades.
Hell no. I was a knucklehead. Smoked a lot of weed, dropped out of high school. But Freedom House trained me up. Saved my life.
What are you doing there, Willie?
Nothing.
You're moving your old pacemaker.
So the patient is rotating or twiddling his pacemaker box under the skin. This is called Twiddler syndrome. This causes the lids to disconnect from the pacemaker box and could even cause lid fracture. Chest x-ray shows coiled or displaced lids around the generator, exactly like in this case. The treatment here would include repositioning of the lids if they are intact and undamaged and not fractured. Then we gotta replace or re-secure the pulse generator. If the pacemaker is still intact, it could be reused. But here, since it's going to be replaced, I guess the header port where the lids connect has been damaged due to manipulation and twisting. That's why surgery is indicated here to replace the pacemaker with a new one. Also, twisting can cause internal circuitry stress and cause malfunction of the device too. In that case, a new pacemaker has to be replaced by removing the old one with surgery.
Diagnosis made.
What?
Twiddler syndrome. Spinning that thing around caused the wires to break off.
Dad.
I didn't mean to.
Well, it's okay. We'll put the new one in a little deeper. Won't happen again.
Not only deep, we got a suture to anchor the device more firmly besides educating the patient not to manipulate the area.
Some of your tests are concerning for a kidney stone.
Wouldn't that give more pain?
Not always.
So, findings suggestive of kidney stones in urinalysis would be hematuria, crystals like calcium oxalate or phosphate, and also pyuria or pus cells if there is infection. Kidney stone pain, also called renal colic, is an intense pain that comes in waves due to ureteric spasm, trying to remove the stone obstructing it. It is a typical flank pain, intermittent in nature and severe, associated with nausea and vomiting, dysuria, and hematuria.
If it's a urine infection with a stone, you'll need to stay in the hospital for some IV antibiotics.
For kidney stones, we provide pain relief and antiemetics. IV antibiotics are usually not given. They are given if it presents with signs of infection like fever, chills, elevated WBC, and positive urine culture.
What do we have to do?
A CT scan of your kidneys.
Non-contrast CT abdomen pelvis is the gold standard for diagnosis of nephrolithiasis.
How long is that going to take?
They can do it right now.
Oh, great. Let's go.
I'm sorry there's radiation. You won't be able to stay with her, but we'll be back as soon as the scan's done.
You're good with this, right?
Yeah, I'll be fine.
So, Laura's an accountant?
Uh-huh.
How'd you get the job?
Online ad.
Yeah.
Zoom interview.
You must be good at math.
Not really.
So what do you do for work?
I answer the phones, I make appointments, I bring deposits to the bank.
You work with spreadsheets?
She hasn't taught me that yet. This is where you do the CT?
Definitely not. They just made up a false suspicion of nephrolithiasis to buy her some private time for further inquiry about the suspicious boss and for a pelvic exam, I guess.
No. We wanted to give you some privacy for your pelvic exam.
Laura's gonna be so pissed.
Why would she be mad?
Piper, you have any concerns you want to talk about?
No, just the pain when I pee.
Anything you need to tell us about your job or your boss?
No, it's all really great.
Then, why would another person be pissed of a patient's necessary pelvic exam?
Okay. Temp is up to 91.
She's so much warmer. It's working.
Can you shock the heart now?
91 is warm enough for her heart to respond.
Oh, compressions.
So, the only cause that seemed reversible here was the hypothermia. It has been somewhat alleviated, and still the heart hasn't responded to the CPR and epinephrine by either resuming its normal sinus rhythm or converting into a shockable rhythm like V-fib or V-tach. It's still a systole, and this can't be shocked.
Asystole.
Resuming compressions. Got the potassium level back, 12.2.
Drowning causes hypoxia, with the lungs being filled with water and unable to become oxygenated. This lack of oxygen in tissues causes cellular injury and death. When cells die, potassium leaks out into the extracellular space and bloodstream, causing hyperkalemia. The patient was likely underwater for a significant amount of time, hence the potassium elevation was also significantly high as more cellular death occurred due to more hypoxia. Different potassium levels correlate with different types of arrhythmias. For extreme potassium elevation above 8 to 9, there is risk of cardiac arrest rhythms like asystole, and that's likely what happened here.
No one has ever survived a cardiac arrest with a potassium over 11. There is absolutely no chance of recovery. I am so sorry. Amber has died.
This is such a heart-wrenching experience, especially in real life. To tell someone that their beloved has died takes a part of my soul every time. It's worse if it's a little child and the death is sudden and completely unexpected.
No, it's not happening. No.
Before we stop, do you think her sister would like a chance to say goodbye?
No, Bella shouldn't see her like this.
Okay. You can stay in here for as long as you like.
It's okay. It's okay.
We are going to stop now.
No return of spontaneous circulation after continuous CPR and epinephrine for several minutes, no reversible cause, no shockable rhythm, and the patient is declared dead.
Resuscitation efforts discontinued, 1451.
Baby. Oh, sweet. Sorry.
Okay, that's it. We're done.
Let me get the gurney up.
Is everything okay?
Yeah. There's no infection in your uterus or ovaries.
As said before, the pelvic exam here being normal has ruled out pelvic inflammatory disease, meaning infection of the upper female reproductive tract, including uterus, fallopian tubes, ovaries, and cervix. It has also ruled out ovarian cyst or mass as a possible cause of the lower abdominal pain and tenderness.
Okay, that's good.
But your urine test was positive for chlamydia.
Shit.
Chlamydia is an STD caused by Chlamydia trachomatis, with risk factors being multiple sexual partners, unprotected sex, and young age. It is asymptomatic in 70% of females, and when it is symptomatic, it can present with abnormal vaginal discharge, burning micturition, lower abdominal pain, bleeding between periods or after sex, or painful intercourse. This could explain her symptoms too.
It's a sexually transmitted infection. Any idea how that happened?
Yeah, my cheating piece of shit ex-boyfriend back home. But we broke up before I moved.
You need antibiotics twice a day for 10 days.
Treatment of chlamydia includes antibiotics like doxycycline 100 milligrams orally twice daily for 10 days. Both the sexual partners are to be treated simultaneously. Patient is asked to abstain from sex until treatment completion and symptoms resolve, and also advised for regular condom use and avoid multiple sexual partners.
That'll clear it up, and he'll need treatment too. You should also test for HIV, syphilis, gonorrhea, and hepatitis.
If one STD is positive in a patient and all STDs are caused due to multiple partners and unprotected sex, the other causes of STDs are also to be looked for.
Okay.
Any other sexual partners in the last few months?
Not really.
Use condoms?
Most of the time.
It's important to use them all the time.
Yeah, but if I forget, you can just give me a shot, right?
Unprotected sex could result in unwanted pregnancy too. Also, all STDs aren't easily treated. Some could progress into life-threatening complications, and others don't have proper cure like HIV.
Not for some infections, this is serious.
Birth control?
Norplant. It's good for 5 years.
Piper, we have a question that we ask everyone. Sometimes people are pressured to have sex when they don't want to. Does that ever happen to you?
No, never.
When you signed in, you put down Laura as your emergency contact.
Yeah.
You have the same address as Laura?
Yeah, she's letting me use her guest room until I can save up for a place of my own.
Okay. Why don't we have you lie down again?
What for?
Ultrasound, we're gonna check your kidneys.
I guess the doctor isn't satisfied with her answers or is simply not buying it.
You got bumped from CT by a couple emergency cases.
Bella, Dr. King and Dr. Collins are here.
Hi, I'm coloring.
You're a very good artist.
Thanks.
Bella?
Children at such a tender age don't fully understand death as a permanent loss of a loved one, so it's important to speak gently but clearly. Be honest, simple, and gentle. Allow her to ask questions. Validate her emotions and reassure her.
What have you heard about Amber?
She's really sick, but the doctor and the nurse is trying to make her better.
Must make you sad. You know, I have a sister too, and I don't like it when she's sick.
She saved me.
She did.
I fell in the pool. She helped me get out, but then she couldn't get out.
That's even more unfortunate. She died trying to save her little sister. This would hurt even more when she understands fully as she grows up.
I'm making her a card.
Freedom House took us in and trained us for 300 hours.
They turned out the very first medics in the United States.
We started IVs, defibrillated, intubated in the field.
This reminds me of working in remote village areas where there is nothing but you and some very basic meds and instruments, and you gotta make work of it as much as possible. A place where even intubation isn't possible, no x-rays, no nothing, just you and some extremely basic meds. However, the upside is the ambience and the people whom you serve. The people of the villages are much more appreciative of a doctor's services than the people in the cities.
They were the heroes of Hill District. Bunch of young black dudes saving lives every day.
Why'd you quit?
I didn't.
The city saw how successful it was, took over the program, trained new medics.
All white.
Everything that Willie and his friends did set the EMS standard for the entire country. Their program created the 911 system.
It wasn't just us. We had the best teachers. Dr. Saffer invented CPR.
In the mid-20th century, doctors like Peter Saffer and James Elam advanced the understanding and practice of artificial respiration, including mouth-to-mouth resuscitation. In 1960, doctors Jude, Knickerbocker, and Cohenhoven published their landmark paper named Cardiopulmonary Resuscitation, which combined chest compressions with mouth-to-mouth breathing, creating the modern CPR we use today. William Cohenhoven, who is the father of cardiopulmonary resuscitation, during his research on defibrillation, found that rhythmic pressure on the chest could maintain circulation, and that relaxation of this pressure allowed the heart to refill. This suggested that CPR could preserve cerebral perfusion as long as it is given. CPR generates a partial cardiac output, about 20-30% of normal, but it's enough to slow down brain injury.
Dr. Adamson, med student when I arrived. But I'm telling you, boy, that guy could teach like there was no tomorrow. You ever hear him give a lecture?
Many times.
Every time I save a patient, it's like he's standing right here, whispering in my ear, telling me what to do.
Me too.
Dr. Adamson was the mentor of Dr. Robbie. Most of the things you learn in residency is learned from your mentor and colleagues and seniors.
Where's he working now?
Dr. Adamson died a few years ago during COVID.
Oh, hard to believe. He was so young, so full of life, force of nature.
Yes, he was.
I finished my card.
Oh. It's beautiful. I love it.
Thanks. Can I see Amber now?
Not quite yet.
What is that?
Oh, it's from the gift shop.
For Amber?
For you and for Amber. But you get to name it.
I think her name will be Bear.
All right.
Medicine is all about being a good communicator. You can learn all the necessary medical knowledge and skills and expertise in procedures and all that all along the way, but not being able to talk to patients as efficiently would always limit you from becoming the best doctor. Here, the doc is compassionate and kind and gentle with her words. She is a great communicator, as was indicated with her being able to communicate effectively with the autistic patient before as well.
Since you can't see Amber right now, but I bet you got a lot of things to tell her, Bear's gonna help.
How?
Well, if you tell Bear everything you want to tell Amber, then I'll take Bear and sit her on Amber's pillow, and then she'll tell her everything you said. What do you think of that plan?
I like it.
Yeah? Okay. Do you want to give it a try?
So, informing the child of her sister's death isn't direct here. It's a multi-step process, and you would want the news to be delivered to the child in as non-shocking way as possible, while being as gentle as possible with words. Children do not understand the reality of death yet, so this requires careful navigation.
Hi, Amber. It's me, Bella. Thank you for saving me. When you come home, I promise I won't touch your toys without asking. And I try not to fight because you're my best friend in the whole entire world. I love you.
Difficult to hear from the little sister, especially knowing that she's never coming back.
Amber's gonna be so happy with that.
Hey.
Hi.
How long have you been working here?
32 years.
All in the ER?
Yeah.
Oh, man. How do you do it?
Honestly speaking, time just flies, and you'd never know when you are old. The common cases become routine, delivering bad news never becomes easy, and you'd be accustomed to working long hours.
I like taking care of everyone, especially the ones who fall through the cracks. They got nowhere else to go.
We all went into medicine to help other people in need. Altruism is the way to go.
Well, you deserve a medal.
I'd settle for a raise. Thank you for everything.
I wish they could do the surgery here.
Surgical teams are flying in from all over the country to meet Nick at the Center for Organ Recovery.
The organ retrieval surgery is conducted in OT by transplant surgical teams. They remove solid organs like heart, lungs, liver, kidneys, and pancreas, and tissues like cornea, skin, bone, and valves as per consent. The organs are flushed with cold preservative solution, stored in sterile containers on ice, and transported immediately to recipient centers. The recipient is already prepared and waiting. Transplant surgery starts once organ arrives, and post-op immunosuppressive therapy is initiated after. The retrieved organs are transplanted as quickly as possible. There is a very short time window between organ retrieval and transplantation, known as the cold ischemia time, which is the maximum time the organs can be preserved, about 4 to 6 hours for heart.
We have a car and driver waiting so John and Lily can follow right behind the ambulance.
Thank you. So we won't be seeing you again?
If it's all right, I think a lot of us here would like to attend Nick's funeral.
That's a great way to show respect to the patient whom you treated and who unfortunately lost his life.
Yeah, of course.
This is the honor walk. The patient is being transported to transplant center. Hospital staff, family, and the general public have lined up the hallways as the donor is wheeled from the ICU to the ambulance. An incredible ending to the fentanyl overdose teen case. Thanks for watching. Have a great day. See you in the next one.